Assalamu alaikum. Today we're going to speak about the history taking of cardiovascular system and renal system. The first part would be history about the cardiovascular system. The history taking for cardiovascular system and is similar to all other systems. So it's not unique to cardiovascular system. So the following rule which will be mentioned in this lecture should follow in history taking of any complaint and related to any system. Why the history is important? Importance of history taking is very crucial in the patient, in determining the patient etiology. Not only it identifies the etiology of the patient problem as a diagnosis, but also it is important in communication, important in guidance of management and treatment you give to your patient. So it's affect all aspects of the management. 70% of the diagnosis is based on history alone, and sometimes even 100% is based on history alone. You should avoid stories, avoid medical jargons, and there's a huge difference between history taking by doctors and narration story. The components of medical history, not only cardiovascular and renal, but all medical histories are the same, and you should follow this frame all the time. It first includes personal data, chief complaint, present illness, past medical, past surgical history, systemic inquiry, family history, drug history, social history, and sometimes we add gynecological history, travel history, obstetrical history, of course, and blood transfusion. At the end of all histories, you should include patient concerns, beliefs, and expectations. How to take the history? The history taking is a skill, and to acquire this skill, you have to learn more about diseases and you have to practice history taking. Without practice, believe me, this seemingly easy part of medical practice will be very difficult if you don't have practice. So it is an art which you have to acquire. To acquire any skill, you need lots of practice. The components of medical history is a frame for an appropriate history. The importance of these components are equal, but we put them in a frame in order not to miss any one of these. Listening skill is vital. Asking questions skill is important. Simple, not complicated knowledge is needed to take a successful history. General approach. First, greet your patient and introduce yourself. Don't never forget the patient name. And it's better for communication and to keep a good doctor-patient relationship to name your patient by his loved name. Create a friendly way. Ensure confidentiality and you should respect privacy. Always exhibit a natural position with your patient. Shouldn't be too close or too far from your patient. Understand patient mental status and anxieties and even cultural and educational background. Questioning is simple. It should be simple, clear. You should avoid medical terms, jargons, and you should avoid open question or direct question. Finally, you have to summarize. Listening skill is very important and listen carefully and show attention to your patient. Personal data is very vital and do it with which you start. You record his name, age or her name, age, address, sex, ethnicity, occupation, marital status. Record the date of examination and record your name and the site where the history was taken. Complete history taking by chief complaint, then history presenting complaint, past medical, surgical, systemic inquiry, family history, drug history, social history, patient concerns, beliefs, and expectations. We're going to start by chief complaint. Chief complaint is the main reason why the patient came to you. and usually a single symptom. Occasionally could be multiple. The patient should describe his problem or problems in his own words. It should be recorded by the patient own words in your notes also. You should use an open question all the time. Don't start by directed or close the question. Start by an open question like what hurt you here? What is your complaint? What's the problem? Etc. The chief complaint should be short and specific. Put it in one clear sentence. Communicating present, major problem and issue. It should include also timing and recurrence. Avoid writing medical terms in the spot. Patient complaint should be written by patient language and you should avoid medical terminology. History presenting complaint, it covers the details of this chief complaint, relevant associated symptoms, have a differential diagnosis in mind, and decide the way to importance for complaints. The major complaint of the cardiovascular system is the chest pain, and such you have to cover all the aspects of pain, like timing, onset, mode of evaluation, and investigation done, and treatment given and its efficacy. Ask about OBQRS T for each symptom. Chest pain, ask about onset, position, quality, radiation, relieving factors, relationship to body function or position, severity, timing, treatment given, and any other associations. Again, if the complaint is not chest pain, as for instance dyspnea, which is the second major complaint of the cardiovascular system, you should also ask about the onset, how it started, the position or site, the quality and nature of the dyspnea, relationship to exertion or patient position like orthopnea or paroxysmal nocturnal dyspnea, how it's severe, and you should ask about this regarding a scale, how far patient can walk without getting dyspnea, the timing, the variation of the day, and treatment given and its efficacy. In past medical history, you have to ask about anything related to the heart disease. Ask him about history of any previous history. If patient says no, don't stop. Ask him in more details any history of ischemic heart disease, heart attacks, diabetes, hypertension are the major risk factors for cardiovascular disease. But also you can ask about any renal disease, liver diseases, and chronic infectious disease like TB. Past surgical and past medical history, ask about any cardiac surgery done, and if there is any surgery done, what is the indication for the surgery, how the operative period was, and the post-operative complication, whether early or late. History of trauma or accident, sometimes it's essential. Drug history, always ask about drug history, even over-counter medication and herbals. And mention the frequency patient taking these medications. Of the history of the cardiac disease, you should know all the medication which is patient taking, as it can be linked to a presenting complaint. In family history, ask about familial diseases. General question is again is mandatory. Any diseases running in your family, and specifically you ask about ischemic heart disease, hypertension, diabetes, or genetic diseases. Social history is very vital for cardiovascular history to know about the patient's smoking history and the duration and the type, and you should always count back year smoking, drinking history, amount, duration, and type. Occupation can be cardiovascular disease, housing condition, social background, educational background, presence of family and social support if you want to discharge the patient, and financial situation. Again, about financial situation, don't ask the patient whether you have money or not. Ask him about it. Generally, financial aspect of his life. Is there any struggles? Other relevant history which we need to take: obstetrical history and gynecological history, immunization, travel, sexual history, and blood transfusion. Systemic review. This is a guide not to miss anything. Any significant finding should be moved to the presenting complaint, or past medical history. This is dependent on upon you where you think this belongs. Don't forget to ask about status symptoms of the cardiovascular disease in the systemic inquiry of other systems. General systemic review, we ask about weakness, fatigue, anorexia, change in weight, fever, lumps, night sweats. Cardiovascular system is the main system which we take, but again, if you take history about other systems, you ask about chest pain, paroxysmal nocturnal dyspnea, orthopnea, shortness with cough. Once we are speaking about cardiovascular system, the chest pain of cardiovascular system could be anginal or non-anginal, like pericardial disease. And again, you have to ask about the characteristics of the pain, taking into account the Socrates. And then you have to put a differential diagnosis first, whether this pain is anginal or not. Paroxysmal nocturnal dyspnea and orthopnea both are identified as dyspnea, but orthopnea is on lying flat, and this is characteristic for heart failure. And paroxysmal nocturnal dyspnea is when patient is able to lie flat, but at the middle of night he wakes up with dyspnea. This suggestive of left ventricular dysfunction. Shortness of breath in cardiac disease is also common. It can be an anginal in cause, like chest pain mimics, and can be a sign of heart failure, pericardial effusion, tamponade, or valvular heart disease. Cough and sputum in heart disease, it is usually pinkish and frothy and bloody. It can be due to pulmonary edema or aortic aneurysm. Or pulmonary embolism. Swelling of the ankle, lower limb edema, is common in lower limb disease. Palpitation is a common presentation of cardiovascular disease, and you have to ask about the timing of the palpitation, the nature, and you ask your patient to tap this palpitation, how it is regular, irregular, etc. And cyanosis. Respiratory system, ask about cough, pneumothorax, chest pain, shortness of breath, tachypnea. GIT system, appetite, diet, nausea, vomiting, regurgitation, abdominal pain, distension, hemoptysis, melena. Systemic inquiry of the urinary system, ask about any urinary problems like frequency, dysuria, urgency, hesitancy, terminal dripping, nocturia, back pain, and character of the urine and its color. Genital system, ask about pain and discharge. Musculoskeletal system, again, pain and discharge. Nervous system. There is a link between nervous system and cardiovascular system. Should ask about an abnormalities to the gait, headache, abnormal movement like convulsions, alteration level of consciousness, muscle weakness, paralysis, abnormal sensation, tremor, and change in the meditation and behavior. Ask about patient concerns, beliefs, and expectations. Summarize and ask the patient any relevant information he wants to add to you. So ask him generally whether he thinks anything relevant I have to know. Give him a clear plan and ask permission for examination. The history taking skill makes a difference. Cardiovascular system examination. The cardiovascular system examination includes general examination and cardiac examination, peripheral vascular system examination. General approach, general appearance, whether patient have features of Marfan syndrome, tall, long extremities. This is associated with aortic root dilatation, mitral valve prolapse. Acromegalic features like large stature, coarse facial features, spade-like hands, associated with cardiac hypertrophy. Turner, female with webbed neck, hypertelorism, short stature, associated with aortic coarctation and pulmonary stenosis. So with the right with the pulmonary aortic abnormalities. Friedreich's ataxia, which is abnormal gait, ataxic gait, with Biscamus and Hamartus, is associated with hypertrophic cardiomyopathy and cholic spondylitis, straight back syndrome, stiff back is stiff and associated with aortic regurgitation and congestive heart failure. Quicken syndrome associated with right side heart failure and pulmonary hypertension, with the patient is severely obese and sleepy. In presence of hereditary hemorrhagic telangiectasia associated with pulmonary arteriovenous fistula, lupus features associated with valvular disease and myocarditis and endocarditis, and which is called Lehmann-Sachs endocarditis, and pericarditis, which is the most common. Phacocytoma, pale, dark skin with associated with phacocytoma, sarcoidosis, cutaneous nodules, erythema nodosum, lupus purulent associated with secondary cardiomyopathy and heart block. Tuberous sclerosis, angiofibromas associated with rhabdomyolysis, myxedema associated with congestive heart failure and pericardial effusion, and even tamponade. Blood pressure should be taken. Signs of heart failure should be looked for, especially on lymphedema. Fundus examination is always mandatory to mention, as you can see signs of infective endocarditis, diabetes, and hypertensive changes, and vasculitis, retinal venous occlusion or retinal artery occlusion, whether central or peripheral, is considered cardiovascular disease. Arterial pulse, you take the radial pulse. First you take radial delay, radiofemoral delay, then you count the pulse rate, rhythm, form of waves, volume, and visual wall tone. GVB is measured at 45 degrees and it should be differentiated by carotid. It has two waves. The main wave is downward wave and it easily compressible, and it can associate with hepatojugular reflux and can move the air loop. The heart examination, first start by inspection for epic speed, left parasternal movement due to right ventricular hypertrophy, and pulsation in the second left intercostal space, and epigastric pulsation of abdominal aortic aneurysm. Palpation of the heart includes identifying the epic speed at the fifth intercostal space, mid-clavicular line, which is the normal position, but it can be abnormal, left parasternal heave, and finally thrills over aortic and pulmonary areas. Auscultation, there is no palpation for the heart, so we jump to auscultation. We start by the bell for low-pitched sounds and diaphragm for high-pitched sound. First, you auscultate by the bell. The normal heart auscultation, you hear audible first and second high sounds. Added sounds are third, fourth, and high sounds, and recorded frictional rub, opening snap, and mitral click, which is very rare to be listened. And finally, murmurs. Murmurs, what is the murmurs? The murmurs are turbulent blood flow caused by diseased valve or if a large amount of blood flow through a normal valve. Characteristics of the murmur suggest the cause of it, like timing, localization, radiation, and relation to respiratory cycle and its intensity. But generally, you should be aware that the diastolic murmur are identified by the Systolic murmur identified by the radiation site, and diastolic murmur identified by the localization. So it doesn't go anywhere. There is no radiation for the diastolic murmurs. Site over which area murmur is specified depending on the valve origin. Mitral valve at apex, aortic valve at second space, for example. Radiation occur along line of flow blood, aortic stenosis to the neck, mitral to the axilla, etc. Cortication between scapulae. The pitch, the greater the pressure gradient, the higher the pitch. And mitral stenosis, for instance, it is a low-pitched sound because the pressure gradient is low. But in aortic regurgitation, it is high-pitched because the pressure gradient is higher. Timing in relation to the first and second heart sound. Systolic is between first and second heart sound, and diastolic is between second and first heart sound. The grading of the murmur, usually we have 6 grades of the murmur for systolic murmur and 4 grades for diastolic murmur. The grade 1 murmur heard with a stethoscope, but not at first, and it needs expert to be auscultated. Grade 2 faint murmur heard with a stethoscope in a chest wall. Grade 3 murmur heard with a stethoscope in a chest wall, which is louder than grade 2, and here you can start hearing murmurs, but it has no thrills. Once a thrill is auscultated with murmur, it means that it is grade 4. Grade 5 and 6 only for systolic murmurs. 5 heard with a just rim of the stethoscope is pressed against the chest wall. And grade 6, when the stethoscope is away from the chest wall, you can auscultate. Example of murmur: systolic murmur like mitral regurgitation, tricuspid regurgitation, aortic stenosis, and pulmonary stenosis. Diastolic murmur like mitral and pulmonary stenosis, tricuspid stenosis, and aortic regurgitation. Continuous murmur, PDA, and fistula. Signs of heart failure: elevated GVP, gallop rhythm, basal crickles, hepatomegaly, circular edema, and lower limb edema. Examination of the peripheral system, arteries and veins. The pulse can be examined, should be examined, and what they are. You need to examine radial pulse, brachial pulse, axillary or subclavian, carotid, femoral, and popliteal, and dorsalis pedis pulse, posterior tibial pulse. Examination of the peripheral vein. Sometimes you need to examine for peripheral venous system, which you should see edema and venous ischemia with cyanosis. That's all about the cardiovascular system. I believe there's lots of questions and lots of things to be clarified, and if we be able to see you in a bedside, we're gonna speak about it. So write down your questions, the point which you didn't understand, the questions which you have, and I will be happy to answer these questions at bedside sessions. The renal system history and examination. I'm gonna speak a little about the history of the renal system. I'm gonna focus about examination more, as we have spoken in the cardiovascular system examination. The frame of history and the importance of history are similar. The complaints of the renal system manifestation is usually multi-system, but the presentation usually those patients come with no complaints, so it's accidental findings. So the silence is the commonest presentation of renal diseases. But the history of renal disease should focus about past medical history of risk factors like diabetes, hypertension, and abnormal urine analysis. So the problem, they can come with the patient with the renal disease can come to you with the underlying cause of renal disease, abnormal analysis, or problems with pregnancy. The history of renal disease should cover the presenting complaint, and you should especially devote attention to drug history and uremic symptoms. Uremic syndrome which includes anorexia, so you should ask about appetite, weight loss, as this patient can get cachexia, nausea and hiccup, peripheral edema, muscle cramps, pruritus, and restless leg syndrome. The renal system examination involves looking for clinical clues and signs related to end-stage renal disease. For example, fistula denotes patient on dialysis. Dialysis catheter renal transplant means patient have got transplantation. Whether this transplant is functioning or dysfunctioning, you can see signs for that. Renal failure complication like fluid overload and uremic features. Immunosuppressive general medication side effects like tremor, which is cyclosporine A, stria for steroids, and steroid phases for corticosteroid. Causes of renal disease, you can see features, general features for causes like diabetes, hypertension, polycystic kidney disease. To start examination of the renal system, first you have to introduce yourself to the patient and make sure about his name and identity. You should mention your name and your role in medical team and your position. Confirm the patient's name and date of birth so not to confuse patients. Briefly explain what the examination include and get consent, so ask permission. Wash your hands, position your and ensure privacy. Position your patient adequately, expose him and ask him whether he's comfortable or not. General inspection for level of consciousness, pallor, shortness of breath, comfortability, edema, cachexia, uremic complexion like yellow color skin caused by uremia and advanced CKD, or Kashin-Gold appearance of a steroid. Hands should be examined. Inspect the hands for any of the following signs like pallor, which cause underlying anemia due to erythropoietin deficiency, finger prick marks secondary to repeated capillary blood glucose measurements in diabetic patient, gouty tophi on the hands denotes gouty arthritis, which could be secondary to chronic renal disease, and the tremor, which will be secondary to, we're going to speak about tremor later. Look for the nails like phyllonychia of iron deficiency anemia, leukonychia, which denotes hypoalbuminemia, splinter hemorrhages denotes vasculitis, trauma, or affective endocarditis, Buse lines, which one or more palpable transverse ridges in the nail plate is associated with malnutrition and systemic diseases, Mohrix lines, one or more pale transverse bands, not palpable like Buse lines, extending all the way across the nail bed associated with hypoalbuminemia. Lancet half and half nails is a wide discoloration of the proximal portion of the nail and red-brown discoloration of the distal portion of the nail. It's associated, commonly seen in hemodialysis patients. Astraxis. Look for tremor and astraxis. Tremor is a final tremor can be seen in patients with renal replacement on cyclosporine A. But astraxis denotes failures. It's associated with renal failure, four failures. Associated with renal failure, heart failure, liver failure, and respiratory failure. To demonstrate this, ask patients to stretch their arms out in front of them. Ask them dorsiflex their wrist and hold it for 30 seconds. Observe for any astraxis. Skin turgor is examined by gently pitching a fold of skin. This can be done on the back of the hand in a young patient, but in elderly we prefer to do this in a forehead, holding the skin pitch for a few seconds and then release it. Generally it will go released and disappear quickly, but in dehydrated patient it will return very slowly. Inspect the arms for excoriation that indicates pruritus, which is seen in uremia. Bruising can be seen in excessive corticosteroid use or platelet dysfunction due to uremia. Warts or skin cancer can be associated with immunosuppressive medication, especially azathioprine. AV fistula in the wrist which is very vital to look. It can be at the wrist or at antecubical fossa, so you have to look for these signs. Palpate if you see the fistula, at once you have to palpate the fistula for thrill, and auscultate at once before skipping this area. Auscultate for bruise, and this gives you an idea whether this functioning fistula or not. And again, if you want to know whether this fistula is in use or not, you just look for any recent pinprick punctures at the fistula site. That means it has been in use. Then you take radial pulse. Blood pressure should be measured, and it can be renal disease. We can see hypertension. The attention need to not to measure blood pressure on the AV fistula site. First, look for skin color and skin lesion. Complexion of the patient and facial expression is very important. Yellow complexion notes uremic feature of chronic renal failure, and uremic frost patients are usually do crystalloiduria deposits found on the skin of the patient, not only face but generally face and hands, and seen in advanced renal diseases. Skin lesion may develop secondary to immunosuppressive medications like squamous cell carcinoma and basal cell carcinoma. Cushingoid facial appearance, hypertrichosis seen in using cyclosporine A as treatment for renal transplantation patient. Patient wearing hearing aid denotes Alport syndrome as a cause of glomerulonephritis. Eyes, you should look for periorbital edema, suggestive of nephrotic syndrome, conjunctival pallor, and jaundice. Band keratopathy is a corneal disease caused by a deposition of calcium in the central cornea. Symptoms include eye pain, and if this is central cornea, ultimately you will have reduced visual acuity. It's seen in hypercalcemia. Hypercalcemia renal disease seen usually in multiple myeloma and malignancy. Periorbital edema, swelling around the eye, is a common clinical feature of nephrotic syndrome. Mouth. Look for mouth for gingival hypertrophy, which is seen in the cyclosporine A use. Uremic fetor, which is ammonia smell, is usually seen in end-stage renal disease. GVB should be examined. Inspection of the chest. Examination of the chest. Start by inspection of the skin if there is an excoriation, bruising. Excoriation means for there is pruritus, bruising, platelet dysfunction or anticoagulation, skin lesions, warts of the skin, shape of the chest, and needle track for recent pleurocentesis and the scars and chest tubes. You make sure about the presence of these. Percuss of the chest over all areas, supraclavicular, infraclavicular, anterior chest wall, axilla, and posterior chest wall. If you notice stony dullness, there is the presence of pleural effusion, which is a sign of chronic liver disease or chronic kidney disease or hypoalbuminemia due to nephrotic syndrome. Auscultate the lung basis for pulmonary edema and pleural effusion. For cardiovascular system examination, palpate the apex, and if in case of chronic kidney disease, the apex is shifted usually laterally and downward because we see volume overload. So displacement of the apex denotes ventricular hypertrophy and dilatation. Auscultate the heart by, as we have mentioned, by bell first and then by diaphragm. Auscultate over the 5 areas of the heart and over the lung basis and between scapulae. But make sure to auscultate at the pericardium for pericardial rub. This is very vital in advanced renal disease. Abdominal examination usually start by positioning the patient flat, expose and make the abdomen from nipple line to mid-thigh. Make sure that the patient is comfortable and has no pain and relax his muscles. Look for scars, and this is very vital if you need to see a scar, especially hook stick scar. And look for abdominal distension and abdominal masses. Especially look for right or left iliac fossa for renal transplant scar, which is a bean-like mass, and look for nephrostomy, a tube scar in the posterior wall, which is denotes steroid use and scar related to renal pathology. Palpate the abdomen by light palpation, then deep palpation. By light palpation, look for if you see a mass in the right or left leg fossa or in the right or left flank, like polycystic kidney disease. You should make sure about the size and the shape and the consistency and of this mass and palatability. Then you go to percussion. Shifting dullness is very essential. It denotes ascites, which is a sign of hyperbulimia or CKD. Auscultation for renal pruee, which denotes renal vascular disease. And to complete your examination, explain to the patient that the examination is now finished. Thank the patient for their time. Wash your hands. Summarize your findings. This should be done after an examination. Summarize your finding, and to complete your examination, you need to know blood pressure, fundoscopy, and urine analysis. And thank you for attention. Any question, I'll be happy to answer later. Thank you very much.
خلاص نهائي؟
حسيت مرة ما أقدرش تاني.